As an example, CMS in the Office of Financial Management has been tasked with conducting prepayment review demonstrations. 2 of them are going to begin later this summer. I outlined them here on this slide. One is a pilot using the recovery audit contractors, known as the RACs, to increase the number of prepayment reviews in addition to the carriers themselves. And they are going to be conducted in states where there's been a history of high fraud and abuse and errors in payments. Our understanding is the pilot demonstration beginning this year to run for 3 years will focus initially on hospital services that have produced a significant amount of improper payments. However, CMS reserves the right to move this pilot demonstration over its 3 years to physician, nurse practitioner, and physician assistant claims as well. So we're going to be keeping an eye on that demonstration. And secondly, a demonstration that may impact some of our members in the designated states there is the prior authorization of power mobility devices. And that demonstration requires the provider supplier to submit documents before the power mobility device is delivered. And then CMS is going to render a judgment whether they believe the medical necessity is there based primarily on your face-to-face evaluation and documentation. What we're going to post on the site is that CMS has done a nice job of providing examples of medical record documentation that they consider potentially sufficient, and another example that's potentially insufficient. So I'm going to post those to the site for your reference. And again, you can see the states that this demonstration is going to occur. So there's a lot going on, and as we turn to the next slide, the Academy's concern was increased due to the increased scrutiny of house call practices and by these elements that follow. The payment accuracy concerns of CMS and also of the administration and Congress that have directed CMS and other federal programs to make sure that they are not making payments in error. We are aware of fraud and abuse indictments in related fields. We have had the experience of the service-wide prepayment review of CPT 99350 in New York and Connecticut that due to combined efforts of the Academy and you, our members, hopefully we've been able to end. We see that prepayment review demonstration that is to begin, and we also recognize that with IAH and with ACOs that there's going to be an increase in beneficial house call utilization, and we don't want to have the fact that there's an increase in utilization come across screens and catch someone's attention as a spike that can't be explained when there's actually a demonstration to prove the benefits of the field occurring at the same time. So with this backdrop, the Academy and members have communicated at various levels to CMS and at the highest levels, requesting a waiver from medical record reviews. This is sort of a broad request, and underneath that request, we made certain points that IAH and ACO demonstrations will increase house calls. Reviews triggered by statistically significant growth in house calls would be counterproductive to beneficiaries and to the goals of Congress and CMS. CMS staff working in the Office of Financial Management and other offices on payment accuracy should meet with the Innovation Center staff to understand the benefits of increased house call utilization that we believe and we know from the field and from the VA and other experiences is real and has provided the support for IAH itself. And so essentially what we want within CMS is that the right hand should know what the left hand is doing. CMS, while demonstrations are occurring, should exempt house calls from medical record reviews, at least in the areas of the demonstrations where we expect utilization to increase. And then CMS, moreover, should limit the aggregate number of reviews that any house call provider experiences over a rolling 12-month period. Again, there's various entities that are requesting medical records either pre or post-payment. However, on a practice perspective, it really doesn't change the burden or the cost or the inconvenience, the hassle factor of producing the medical records, and if it's on a prepayment basis of the cash flow issues, regardless of the entity that has made that request. So something that I added into CMS was that it shouldn't matter which is the requesting entity, whether it comes out of CMS nationally, whether it comes out of your particular Medicare Administrative Carrier or MAC, or whether it comes from the recovery audit organizations. Again, it should be an aggregate number that's a reasonable number, and any practice or specific provider should not have to have the burden beyond, some reasonable amount. And the end result of this is that CMS has listened. Administrator Tavener has directed her medical directors to work with the Academy regarding input about house calls, how to identify house calls, house call providers, and how to develop approaches to these waiver requests. So that is, both a tremendous opportunity and something we want to be very careful about, particularly as various models of house calls, settings, and volumes and scale are developing around the country. And then in terms of protecting revenue in a near-term basis, I just want to turn to the e-prescription program and provide you with some information about the incentive payment that would be provided in 2013 based on your e-prescriptions in 2012, and that would be 25 successful e-prescriptions over the course of the year, with 10 of them having occurred for services between January and June, and Medicare having received those by July 31. Medicare has changed the program a bit. It no longer has to be linked to that particular encounter as long as the e-prescription that you're reporting is linked to that beneficiary on a claim for that particular beneficiary. Again, it doesn't have to be driven by that encounter at the moment. In terms of eligibility, physicians, nurse practitioners, physician assistants are eligible for the bonus payments that will occur in 2013 and 2014. And that it would be if 10% or more of your Part B charges come from a denominator, and that denominator group includes the 18 house calls, and knowing the service distribution of house calls, certainly those codes reflect 10% or more of your practice. And then in terms of some additional fine-tuning at the bottom, the eligible provider analysis is performed at the tax identification and national provider identification levels. And if you're practicing under multiple tax identification numbers, you'd report the measure under each one. For the services, the successful e-prescribing this year, you'd receive a 1% bonus as you're receiving payments in 2013. The next slide provides that electronic prescribing has to occur through a qualified system, and this slide provides that definition of a qualified system, and it can be the standalone or part of the certified electronic health records that you have that one of the certifying organizations has approved. So there's two different possibilities of having your system qualified there. And you can see under number 1 what are the functionalities that have to be in place for the service, for the system to be qualified. And then again, or that it's part of certified electronic health record system. If you're not able to successfully prescribe through a qualified system, there will be a 1.5, absent an exemption, there will be a 1.5 reduction in your 2013 payments based on the lack of e-prescribing in 2012, again, unless an exemption attaches. So we've provided the hardship exemption circumstances there, and we want to make sure that as we're just, again, through the first quarter now, that you have plenty of opportunity to make use of, where applicable, one of the exemption opportunities. And then there's additional information on how to submit a hardship request. And any questions about this, of course, can be directed to me here. Please send in your questions for this afternoon, and if there's some questions we can't get to, we have a bit of a hard stop we have to make this afternoon. We will address those questions back to you in email and posting on the site. Moving on, I want to thank you for attending this afternoon, and look forward to your input. Please provide any questions that you have from the material we've covered today. Let us know if you have requests for more detailed information about what we covered. Let us know about its relevance for your practice model, or provide us some details about how we can meet your needs and respond in a way that's relevant for your practices. In terms of topics for future webinars, the HCC scoring had been planned with the use of clinical vignettes, and this is based on the recognition that HCC scoring will become more and more important based on evolving payment systems and systems at projecting cost that is expected for a beneficiary population or a patient population, and comparing to the actual practice performance against that expected. In order that we can help you with things such as the waiver request to CMS, or on any specific issues, or even fine-tuning your own practice operations from a benchmarking perspective, we really need to receive practice metrics. We've posted a survey to the site. Again, this is critical for benchmarking and advocacy in terms of what are norms, what are ranges, and again, we're not going to. We don't want to restrict the field. We don't want to develop the rope and create a noose around any practices or around the field by getting too specific. But we need to know what are ranges, what are the metrics and practice performances out there, so we can advocate for best advocate for you. The Academy is successful, but we find that we're increasingly asked for data, and again, we want to be able to advocate for the field and to protect your interest and your services to patients, beneficiaries, and your revenue as well. If you would like some help in identifying the data sources for that, please let me know, and we can help you identify the data sources for that practice survey and help you with the entering it. or if that can be that information can be faxed or emailed to us, or you can have us put in touch with a practice organization or vendor that produces year-end financial reports or operational reports. We'd be glad to work with the information provided. Want to also note the annual meeting in less than 2 months from now. It's going to be a really super meeting, a lot of great information and sessions and networking opportunities. If there are additional topics regarding practice operations and management, please submit those to me. Also want to point out that the early bird registration ends this Saturday. So if you've been wondering, beyond unfortunately beyond gas prices, you may want to make use of the early bird pricing and join your colleagues in the Academy in Seattle in the beginning of May. A question that's come in does relate to a service being denied due to place of service, being in the home for smoking cessation. So if the member that generated this one will follow up with me. Again, this is the type of activity that we can only educate your Medicare administrative carriers by getting involved with the actual situation. So this is unfortunately where you have a service denied due to a place of service. That's not great, but this is the opportunity for your Academy to work with you. A new initiative. Another question was about, I believe it was the Skilled Nursing Facility Initiative. It was mentioned in the newsletter. CMS put out the request for proposal for 15 facilities around the country to participate. So that was their limiting number. That was not Academy generated. We were just communicating the information. We are actually aware of some members that are working with organizations in their regions to see if they can put together a proposal to submit. That also reflects the importance of the whole care transitions, readmissions avoidance area, and that is one that the Academy is going to be, again, devoting more resources, and there's going to be activity beginning at the, or continuing, and being organized at the annual meeting around that topic, and a real opportunity for you in the field to interact with others on that important clinical and patient care and financial issue. The following question, again, I want to follow up with the individual who submitted it, the demonstration, whether it's regarding billing or will it tie into IH. That initiative that was announced this week is a distinct standalone. The letters of interest for IH, again, the closing date was in early February, and as with others, we're looking forward to the announcement of identified practices, and we do recognize that the detailed consortium information following the letters of intent are not due until May. Another question came up regarding e-prescribing. That is recognized. Well, there's different ways of reporting through groups, through group reporting, through electronic medical records. I focused on the claims basis, believing that was most applicable to Academy members. Unless you are reporting on the sort of the glommed up levels where there are different levels of requirements for the e-prescribing, it is recognized on an individual basis, and again, if you want some detailed follow-up, I'd be glad to get that information to you. Another question is, are the preventive measure codes valid for house calls in assisted living facilities? Going back to the kind of the construct that preventive services were written for once passed, and once CMS was directed to develop the services, the approach, when they would be, how they should be delivered, how should they be covered and paid. That was to be available to all beneficiaries. Now, as you saw in some of the examples that we discussed this afternoon, it is clear that CMS did provide where preventive services would not be considered appropriate, such as emergency rooms, inpatient locations, independent testing facilities, because those are not primary care locations. So there was a focus on, there's a focus in their carrier manual language in terms of the office setting, but with house calls being rendered in the home and assisted living facilities in lieu of the office setting, in a sense, for the beneficiary not being able to get to an office through no fault of their own, that is their primary care, point of access. So yes, the assisted living facilities and places of services should be as valid as the home. And again, that is a topic we've worked on with regard to the annual wellness visit, getting that identified with certain carriers, and actually in some of the other settings as well, to have them considered locations for primary care services. Okay, well, again, thank you for those questions. Please direct any additional questions to me at gary.swartz@aahcp.org. Remember that early bird opportunity for the annual meeting. Thank you for your support of the Academy, and thank you for joining your colleagues this afternoon. Have a great evening, and we'll talk to you soon. Bye-bye.